Thank you. So good to see everyone joining after such a long weekend, a wonderful time to celebrate a national hero, Dr. Martin Luther King Jr., and all that he's done to advance civil liberties and social progress for the country. And so it's actually quite an honor to be engaged in the maternal equity bundle in this moment and thinking of all that he did to address what tended to be these structures within society that led to poor outcomes and poor experiences for others. And so doing that work, it seems to be quite in service to his legacy. So without further ado, I want to move into our team webinar number 4, where we're going to talk about real data utilization. And we really want this to be a pretty engaged conversation with you all. A couple of important points to note is that this month, given the holidays, and then given this particular holiday, given the most recent holidays at the end of December, and then this holiday, we did not have as much time available to teams to turn in their data. So rather than doing a review of the data that's submitted by the teams, we're going to do basically a needs assessment and understand and learn from teams how we're doing with data. And this seems like a good point to do that, because it's sort of like into the first quarter of presenting this information. And so when we move forward to other slides, we'll get into that conversation. But for those of you who just joined, welcome, welcome. Again, as usual, please type your name and your institution into the chat. Mute yourself while you're not speaking. I will do the same. And then when we have questions, you can raise your hand or also unmute yourself to ask your question. As always, the webinars are recorded and they're uploaded and posted on our webpage. And so with that, you'll be able to obtain CME credits for your participation in the webinars. You can go to the next slide. So, and as I was just saying, so free CME, CEU available also for this webinar, and for previous webinars. So if you join the obstetric hemorrhage or the severe hypertension bundles, then you're interested in watching the recordings, you can claim credits through Boston University. These expire pretty soon, so you can join and look at the webinars for the hemorrhage bundle. Expires on the 18th, which is tomorrow. Here's a password to obtain and to view those. And then same for the hypertension bundle, which will have a little bit more time into the summer. Go to the next slide. So we'll get started with our needs assessment, but when we go to the next slide, this is our agenda for today. We'll have Dr. Lauren Arrington come and talk to us, and we'll talk a little bit about run charts today. But I wanted to just take a moment, as we usually do, to thank our team that helps move the work of the equity bundle forward, the maternal equity bundle. So I wanted to show the pictures of everyone again. We find this really important because we want to make sure that even though you hear us talking, myself, Kaylee, you'll see Claire a lot, and Anna is a big part of it, was one of our students. There are a number of people who've been instrumental in ensuring that this has been a great launch and that the measures represent the work that we're trying to achieve within our institution. So I just wanted to show again and say thank you again to our maternal equity bundle work group. Next slide. So we have got a wonderful number of participating hospitals. So this is a map that shows the participating hospitals. We've got a really good spread across the Eastern Seaboard, some in the West out in Springfield. So I want to say thank you to those teams. Additionally, there are 21 other birthing facilities in the state of Massachusetts. So if you've got partner hospitals or good friends in nursing units that you want to support, joining the maternal equity bundle, we're happy to help. We're happy to help teams on board. It's just a very good showing, and we're really proud and happy to see that we have 19, which is 50% of our hospitals in Massachusetts participating to work towards an AIM bundle that's looking at preventing or eliminating, I should say, preventable maternal morbidity and mortality across our state. So it's terrific. So thank you to all the teams that are participating. Next slide. All right, so I'll turn the microphone over to Kaylee. We're going to go through some questions. So get you guys ready, get your fingers ready, get your mouse, little computer mouse ready, or your clickers ready, so you can answer some questions for us so we can do a really great job of helping you through collecting, reporting, and understanding any of the data or questions that we have for the bundle. So Kaylee.
Thank you, Audra. Hi, everybody. It's good to see you in 2023. We're going to be going through the AIM bundle survey, particularly the equity bundle questions, and just have a few Zoom polls asking about some like sticky points that we've heard over the last few months. So we're going to try and do this quickly so that we can get to our guest speaker. I'm going to leave each Zoom poll up for about 30 seconds. So please answer as soon as you can. Just a reminder about the AIM bundle survey. Submission is the 1st through 10th. As Audra said, due to the holidays in December and January, we've decided not to do a data review on this webinar to allow you all to have a little bit of extra time to submit your data. So if you haven't yet, please do that. Okay, so this first poll, we want to know, what is your greatest challenge to timely submission of AIM bundle data? Not necessarily for the equity bundle, we'll ask that next, but for the previous bundles we've done on opioid use disorder, hemorrhage, and hypertension. We've heard kind of all of these options over the years, but just kind of want to know where you all stand today. And I know that many of you may struggle with more than one of these challenges, but just the single greatest at this point in time. About 10 more seconds. Almost to 50%. Few more people want to weigh in. You can, if you just joined us, we're doing kind of a needs assessment via Zoom on AIM bundle data submission. Awesome. Ending this one. So for kind of previous or AIM bundle data in general, it seems the greatest challenge for folks right now is staff capacity and can't easily access the data needed to complete. Okay, this is really very helpful. And the third being lack of OB staff member who's primarily responsible for data submission. Okay, awesome. Thank you all. So now the next poll up is same question, but specifically, what's your greatest challenge to submitting the maternal equity bundle data? Recognizing that this bundle is, stop sharing, there we go. Okay, here's that second poll coming up. This bundle is different from the other AIM bundles. You know, they were more clinically focused, and this one is more about culture change. So as that relates to data, what is your greatest challenge? I'm seeing staff capacity is still a leading answer as these come in. Leave it up for a few more seconds. Great. So if you can see my screen here, again, looks like staff capacity, data access, and lack of a dedicated OB staff member are still the leading challenges, regardless of which AIM bundle you're submitting for. This is really helpful. Thank you, everybody. All right, moving on to our third poll. This one is if you would prefer to reduce data submission for the previous bundles. For OUD, hemorrhage, and hypertension, they're not currently active, but we know many of you are still submitting data. Would it be helpful if those previous bundles were shortened so that you could dedicate more of your time to the current bundle? Right, leave it up for about 10 more seconds. So far, no preference is the leading answer.
That's really good and actually pretty interesting given, I mean, we have that there for you guys as a tool for you to use. So if it's helpful to use, that's terrific. But sometimes as people are filling out their using the data to fill out the other bundles, they want to keep the structure measures updated, but the process measures take some time. So that was the origin of that question.
Yeah, thank you, Audra. So if you can see my screen, looks like about half of you have no preference, but for some, this would be helpful. So we're going to take these results kind of to our greater PinQuin team and discuss and do what we can to reduce the burden of this. Okay, so those were more general questions. We're going to move into a few specific polls about the equity bundle structure measures. So this first one is around equity team diversity. We want to know how we can better support you with resources and technical assistance. So if there is any particular aspect of diversity on your equity team that you're struggling with as you're working to put that group together, let us know. That could be trying to find people from different roles or departments, folks of different race, ethnicity represented on the team, or finding community representatives. Leave it up for a few more seconds. If you're just joining us again, I'll just say we're doing a brief needs assessment about data submission via Zoom polls. So if you see those on your screen, please take a moment to read them and answer. Great. All right. And this one. So it looks like most of you would like more support around finding community representation for your equity teams. Race, ethnicity second, and roles about 5%. Okay, that's kind of what I guessed, but it's helpful to know that people are interested in more support for all of these. So we'll make sure to provide that. Okay, moving on. Similar question, but this time we want to know which aspect of equity communication you're currently working on and would like more support with. So this would be around, do you need more worksheets on SMART goals or AIM statements, more information on what change concepts are, how to create a driver diagram, or support around your anti-racism statement? I know lots of people are working on that right now. Thank you all so much. Right, got about 50% have answered. All right, so you all would like more guidance on SMART goals and AIM statement than anti-racism, than change concepts. Okay, we got it. I will say, Audra, I don't know if you want to speak to the SMART goals AIM statement a little bit, since we have some time. We did cover this in previous webinars in this series.
We did. I was actually going to ask if we'd use the chat to say a little bit more about that. We gave an example. There's a draft driver diagram with an example of a SMARTY AIM associated. So if you guys can give me a little bit more insight into, other than having like that example, what are ways that we can help walk through? Would it be meeting with your teams one-on-one to offer some coaching to think through what is you're working on and offer some specific suggestions on narrowing in and focusing a particular AIM? Yeah, so I'm just going to check and see if there's any comments in the chat. All right, we see Michelle made a comment, sampling needs to be done after the month is completed based on all deliveries. So Oops, I just lost it. So it doesn't allow for much time once the cases are available, but very true. We can go probably, Kaylee, to the next question. And then again, guys, if there's any comments or thoughts that you have for improving or increasing your support, then if you could give us some more information, that'd be great. So for instance, one-on-one meetings, more examples, have another team come and speak about what it is that they're working on, whatever might be helpful.
Yes.
Yeah, okay.
Thank you, Audra.
And we can give you the link as well, Julian.
Yeah. So we asked this question on December's webinar. We are curious which EMRs are being used out there, because that can also provide some really helpful insight for us about, we could try and find some more EMR specific resources depending on what system you all are using. We've got around 50% participating. Answers still coming in a little bit, so I'll leave it up a little longer. Okay. So it looks like most of you are using Epic. And then we have, and this was a multiple choice question, recognizing that some sites may be using more than one EMR. So Epic and Meditech seem to be the two leading EMRs. All right, wonderful. So moving forward, this is the last poll about equity structure measures. So we've been talking with the Betsy Lehman Center and our partners at Team Birth about collecting PREMs. And if all of you, or if some of you joined us for our first team webinar in October, you may remember that we had the Team Birth team come on and talk to us about implementing PREMs. And something that we've been talking with them and BLC about is implementing our own PREMs. So if there were an option, if hospitals who don't yet collect a PREM, or you're thinking about changing yours, would you be interested in collecting PREMs information via a survey that BLC and Penguin provide to you? And we did make unsure an answer option here. So if you answered unsure, feel free to write in the chat to everybody, or to me or Audra or Claire privately, what you're unsure about. Do you need more information on how this process would work? Just let us know where any hesitation might be to use this. So it looks like most people are a little unsure, and that makes sense. This is just the first time you're hearing about it. You probably need more information. But it seems like several of you would be interested in this. So that's wonderful to hear. Audra, is anything coming through in the chat that you can see?
Sorry, I'm muting. The comment just that made that unsure, because I want to know how it would work and how data would be collected and what would be asked from them. So the question related to we want BLC and Penguin to collect their PREMS data, just probably more information on details and logistics, which we can provide. We'll have a couple of conversations coming up related to PREMS, and so we can talk more about that.
Definitely. All right, awesome. Thanks, everybody.
There was another comment regarding equity goals. Executive leadership, senior management, and board leadership need to support equity goals and to be accountable. Completely agree, Dr. Bamba. It is definitely what needs to happen, and it reflects that in our structure measures. Our structure measures really, to Kaylee's point earlier, this is a very different bundle. And part of the difference is when we're making changes to lead to an improvement and doing QI work, and we're just focusing on what we usually do, which is hypertension or hemorrhage or opioid. That's one thing. In this particular bundle, it is around culture shift, as Kaylee commented, and our structure measures reflect that. The process measures are no different than the other clinical process measures, but the structure measures are, how do we take the concept of, how do I undo racism when we think about racial and ethnic differences? How do I think differently about language? How do I collect this data? It feels very 30,000 foot. It feels outside of reach, and it feels difficult at times. And we're wanting to give very specific and tangible and now also measurable steps forward to help create the structures in place so that doing this work seamlessly moving forward and sustaining the work of thinking about differences in outcomes depending on your subpopulations, where that subpopulation is a racial ethnic group or a language group or rural or geography subset, or maybe potentially even, retired military, whatever your subpopulation is. If we can get in the rhythm of having the structures in place and the processes and practice of collecting that information, we can really start to make a difference in these outcomes. Given the time, Kaylee, I know we had some questions on the process, so I think we probably have time for a couple more. And at 9:25 your time, what is it? 12:25 your time, we'll be able to turn it over to our speaker.
Yes, we have 4 questions left, so we'll do them a bit more quickly. We're into the process measure section now, so please let us know in the poll that just appeared, does your hospital have a reporting system for provider and nurse education completion? So far, I'm seeing mostly yes, but a handful are unsure. Okay, that's interesting. We've heard a variety of answers, so. All right, I'll stop it now. So mostly yes, but a bit of a mix between no and unsure. That's definitely helpful, especially for this process measure question, knowing who's kind of more easily able to answer this than others if you have a system. So great. All right. Our next question. If you were part of the hypertension bundle last year, you'll know we talked a lot about these 2 different definitions of severe hypertension, and our understanding is there's kind of a half and half as to which hospitals are using which definition when we asked this last time around. So we would love to ask again.
And thanks for the comment in the chat where the person said some of the unsure might be because they know that they have a system for collecting information regarding nurses, but not for providers.
But not providers, yes.
Yeah, we could have separated that. Thanks for saying
absolutely.
That.
Yes, thank you. And I've heard that too, just in my emails with folks. So I appreciate that. Right. Few responses still coming in, but I'm going to end. So again, slight majority for severe hypertension is confirmed within 15 minutes, but enough of a minority to say this still feels pretty split. Okay, if anybody has comments on this, please let us know. We are planning to do kind of revisit hypertension as part of this equity webinar series later this spring. So we'll be talking about this definition and more in the coming months. Another question on hypertension. This is the second to last poll. Thank you all for answering all these questions. For timely treatment of hypertension, does your team time 1 hour from the first severe range blood pressure reading or time 1 hour from the second confirmation time severe BP reading? Right. Last few seconds to answer. Right now we're in a dead heat.
Oh, that's interesting.
All right, at the last minute, looks like 1 or 2 more people said 1 hour from the first severe range, but this one seems pretty split as well. So this is very, very interesting.
Yeah, this will help guide our conversation, guys. We'll have a webinar coming up on management of severe hypertension in pregnancy and outcomes. and particularly those by race, ethnicity, and be able to look at that. And actually you'll find, and what a spoiler alert, what I'll tell you, the data that you guys have been reporting in, there hasn't been a disparity or a difference for Black women. It's been white women the non-Hispanic white women who've been reported of not being treated within an hour. So I think it's going to become an interesting conversation.
Yeah, absolutely. Thank you, Audra. So this is the last question we're asking you today. So if you haven't answered yet, the poll is up. We want to know, does your EMR allow you to filter patient charts by race, ethnicity for review? We've heard that this has been a challenge for some. And since this is key to answering the AIM survey and also key to what we're going to be talking about today, this is some of the most important information we'll learn today, I might say. All right, a few more seconds up for any last responses before we move on to Dr. Arrington's presentation. Right. Majority of you said no. Okay, well, that is definitely a barrier to some of these process measures. So again, please feel free to email or put in the chat any comments about any of these poll questions. We may be reaching out for more information, but thank you all for your patience with all of these polls. It's really helpful. Thank you.
Thank you, and thanks to you all for now that we're at the 12:30 mark. Any of you who has just joined, please put in your name and institution into the chat. And without further ado, we'd like to introduce our speaker, Dr. Lauren Arrington, who is a certified nurse midwife and done a considerable amount of impressive work to address racial and ethnic differences and outcomes, as well as within other demographic areas at Georgetown University School of Nursing. And so she's going to talk to us about working with real data on their L&D unit. And so I'll turn it over to you, Dr. Arrington.
Thank you so much for that very kind introduction. And I'm really excited to be here with all of you today. And if it's all right, I'd like to share my screen. Is that okay?
Yes, you can go ahead and it will.
Okay, it'll switch this up.
It'll switch.
Okay, there it is. Can you see my screen?
Yes.
Okay, excellent. All right, well, it's a treat to be here. I've spent a good amount of time in Massachusetts because growing up, my dad lived in Cambridge. So spent a lot of time in that area. And I'm excited to talk with you a little bit about my journey working with race, ethnicity, and language data on a labor and delivery unit. And it's very interesting to see the results of the last poll that for the majority of you, you're not able to pull data by race and ethnicity from your EMR. So we'll talk about that a little bit. And again, my name's Lauren Arrington. And I'm just going to start with a little background about me. So I'm a midwife. I've practiced for 13 years. I've also worked in global health. And right now my full-time job is teaching at Georgetown, but I also do some work practicing clinically still at a hospital in my area. And what I'm going to talk about is a quality improvement project that I completed while I was getting my DNP at Duke University. And what I did for this quality improvement project was essentially launch the peripartum racial and ethnic disparities bundle that was put out by the Alliance for Innovation in Maternal Health. This bundle is no longer available as a standalone bundle, and instead the content of this bundle has been integrated throughout all of the bundles. And I learned a lot from doing this. And one of the things that came out of this for me was an interest in community collaboration and doing a better job of looking at data in a way that can sort of more actionably address inequities. And so I recently wrote about what I called the 5D cycle for health equity, which leverages Black feminism and radical imagination and integrates them into the change management framework, appreciative inquiry, which is something that I used while I was doing my project. So for today, my aspirational objective is that after this conversation, you will be able to identify one solution that you can use to help address a health equity data challenge that you're experiencing right now. And so in order to achieve that, I would love if you do have a challenge that you're working with, if you could share that in the chat, because that will then help me to talk about things that matter to you. And so just pulling the chat down so I can see it. So if you're able to do that, that would be great. And I, as you do that, I'm going to just keep going, and then I'll take a look at the chat in a little bit. All right. So the goals for the quality improvement project that I worked on were to collect and share hospital perinatal disparities data with the goal of using that data to increase understanding of disparities in experience and of care and also perinatal outcomes at our hospital, and to also increase staff awareness of how to address racial and ethnic perinatal health disparities and engage staff in strategies to address those disparities. And so these goals came directly from what my colleagues voiced to me, and they felt that we had a long way to go in terms of thinking about this topic, and that just raising awareness would be a great first start and first step. And so that's what we did, and we used the recommendations in this AIM bundle. And so just a little bit about my hospital. So it's a community hospital outside of a major city on the East Coast. And the initiative was initiated within our maternal child health department, and the department was already participating in many initiatives to improve outcomes and experience of care for our patients, as listed on the left. And on the right, you can see the racial and ethnic identity of individuals who gave birth at our hospital from 2013 to 2018. And this was a crucial piece of data that we needed in order to start to look at our outcomes and experience of care data, and identify if we had inequities in care. And before this initiative was implemented, our unit and essentially our hospital really had never looked at their quality data by race or an ethnicity. And we also had a nursing and midwifery and physician staff that was primarily homogeneous racially, primarily identified as white. And we also had an environment where talking about race, and particularly racism, was not easy. And many staff confided in me that they felt uncomfortable talking about racism, let alone standing up and saying something when they heard racist comments or saw racist behaviors. And so we developed a set of interventions that were designed to try to raise awareness and get people engaged in thinking about the issue of health equity. And we were not able to mandate. I wasn't able to mandate any participation in this initiative. So all activities were voluntary, and the focus was really on making the activities inviting and meaningful. And so in that spirit, we did things like a health equity party. We had raffles, we had workshops. We tried to create lots of ways for people to participate. And you can see a lot of the interventions listed here. We would do snack and learn sessions on the unit. We would do staff meeting presentations. I started a committee on health equity, and that's where our health equity champions really developed. We had grand rounds on health equity. We shared options for people to look at online. videos and modules and do things like taking the implicit association test. We made a commitment across our unit to patient-centered care and developed a handout in English and Spanish that stated that commitment, and that also provided the contact information for our patient advocate. We also added an equity question to our emergency debriefing form that was recommended by the Alliance for Innovation in Maternal Health, that asked about whether or not essentially bias could have impacted the emergent event that occurred. And then we looked at our data and tried to stratify some of our quality data. So that's what I'm going to focus on. And so for this project, the purpose of looking at data stratified by race, ethnicity, and language was to make a case for why we needed this initiative in the first place, and to help target future interventions so that we could purposefully address specific inequities that we identified. And it was very easy for colleagues to say, well, yeah, there are disparities across the country, there are disparities in our state, but I don't really see that here. I don't think that exists here at our hospital. So it seemed really important that we needed to prove essentially that if we and discover if we did have those issues here. And that's really how I framed it, as I feel like we provide great care. I don't feel like anyone is intentionally causing harm or discriminating against patients, but let's see, let's look at our data and see what we can find. Let's explore this. And experience of care data seemed really key, because that's data that's really easily connected to what we as healthcare providers and staff are doing, versus our outcomes data, which I'll talk about later. It was a lot easier for people to say, well, those people are just sicker before they get to us. But you can't say that the experience is due to something outside of the hospital. And so one easy thing for us to look at initially was HCAHPS scores, the Hospital Consumer Assessment of Healthcare Providers and System scores. And I'm not going to share all of the data that we collected, but I'm going to share some examples. And so we looked at scores we looked at all of the questions, and across all of the questions, we looked at how patients responded by race and ethnicity. And this example that you see right here are scores for the question, how would you rate the hospital on a scale of 1 to 10? And these are the responses for patients receiving care on our OB unit from August 2017 to 2018. And the graph shows the percentage of patients who responded with the highest rating of 9 or 10 within each racial and ethnic group. So here, the numerator is the patients who gave the hospital a rating of 9 or 10, and the denominator is the total number of patients within that racial or ethnic group that responded to this survey, that participated in this survey. And so we did this with all of our HCAHPS questions, and then took note of the differences that we found and reflected on why those may have occurred. And this was an easy target because HCAHPS scores were already being collected by our hospital and were very important to our hospital because we participate in a value-based care program, payment program, where we were financially rewarded for high HCAHPS scores, and we could be penalized for low scores. And so this was something that I thought, this will get the attention of people in power. And one thing to note about this data is you can see, in terms of like thinking about inequities and disparities, there's a very low response rate. We averaged about 2,000 people giving birth on our unit each year. And so the response rate is just about a fourth of those. And so that, of course, speaks to the quality of this data. Another thing to think about when pulling this data is how it's reported. And in my experience, I was able to talk with the person in my quality department that was responsible for looking at HCAHPS scores, and she was able to run an analysis that pulled all this data. But when you get this data, it's the way it's reported is that you get I got over 150 pages of data, and it gives you each race with each ethnicity, and then each ethnicity with each race, right? So you get lots of different pairings of race and ethnicity, and you have to decide what exactly you want to use. And so in this example, what I did is pulled each racial group with all the ethnicity groups. So the race Asian with Hispanic and non-Hispanic patients who identified as Asian, and then for Hispanic patients, I pulled that with any race that they identified. So Hispanic patients, regardless of what race they identified as. And so that's just something to think about when you're pulling this sort of data. So we looked at this. Another thing we did is I used as part of the project the interpersonal process of care survey. And this is a tool that looks at experience of care using a Likert scale where higher scores mean better care. And this survey was chosen because there's evidence that provider implicit bias is associated with low interpersonal scale ratings, and this survey in particular has been validated to assess racial and ethnic disparities in experience of care. There's a short and a long version of this survey. We used the long version, but I included all of the discrimination questions, so I pulled 2 discrimination questions that were just on the long version. And you can see here the domains of communication, patient-centered decision-making, and interpersonal style, and then the subscales, and the numbers are the number of questions for each of those subscales. And we also changed the wording in the questions because it refers just to doctors. And so we changed the wording to nurses, midwives, or physicians. And because we wanted to make sure that we were eliciting responses about the experience with all of the providers. And this was administered to 242 of our patients on the postpartum unit on day 1 to day 4, depending on how long they were there. And it was delivered to them via a tablet. And they completed and submitted the survey in private. They had to be able to read either English or Spanish. And so some patients were not able to complete it because of that. The data that I'm going to share from this is just the data where we found statistically significant disparities. And we, in our analysis, in order to run the statistical analysis that we wanted to use, we had to just use the patient groups with the largest number of patients that responded. So we did have 12 patients who identified as Asian who responded, and we weren't able to include them in the statistical analysis. And I think we had 1 patient who identified as American Indian. And so this is one example of where we saw an inequity in experience of care. And so these are the mean scores for communication clarity, the communication clarity subscale by language, race, and ethnicity. And what I'm presenting here is all of the data in a way that sort of lets you see how we sort of moved from where the lowest scores were up to the highest scores. but the matching colors show what was compared. So we compared by language, so Spanish and English. We compared by race, other, Black and white, and we compared by ethnicity, Hispanic, Latinx versus not Hispanic Latinx. And we saw statistical significance, a statistically significant difference for patients who spoke Spanish or took the survey in Spanish versus patients who took the survey in English, for patients who identified racially as other versus patients who identified racially as white, and patients who identified ethnically as Hispanic versus patients who identified ethnically as not Hispanic. Across all of our data, the trend that we saw was that white, English-speaking, non-Hispanic patients tended to have higher scores, but they were not always statistically significant. So we didn't have a statistically significant difference between the scores of our Black patients and our white patients, for example. And that's one thing to think about when you're looking at data on at your hospital. Often to get statistical significance, you need a lot of data. And just because something is not statistically significant doesn't mean that it may not be clinically significant and something that you want to focus on. I'll also say that for us, another thing that we looked at was, of the patients who identified racially as other, what were their other demographic characteristics? And most of our patients who identified racially as other identified ethnically as Hispanic or Latinx and spoke Spanish. So that was just a trend in our data. And I'll just show you one other slide that shows our discrimination subscale. And across our discrimination subscale, we also saw the exact same trend, where patients who took the survey in Spanish, identified racially as other, or identified ethnically as Hispanic or Latinx, were more likely to report discrimination, because here the mean score means better care. Okay. So this was a good exercise. I'm just going to go back for 1 second, and it represents sort of traditionally how we do disparities data, where we stratify our racial groups and we compare them, and we determine if a disparity exists, largely based on whether or not one racial group has a much more favorable outcome. And in most cases, in a lot of cases, especially in maternal health, we see that white patients end up with the more favorable outcome, and just disparities data across the country and other areas of healthcare, we tend to set white individuals, their experience, their outcomes as the default and sort of standard that everyone else should aspire to. That's not necessarily the best practice, though. And so I just want to share that after we did this, later on, I was able to get our hospital to participate in another study. And what this study showed for me is that when we're looking at experience of care, we have to always think about, are we asking the right questions? And are we asking them in the right setting? Because even in the way that I conducted my experience of care survey, we didn't have an outside objective person who was able to come in and even administer the survey, which could have impacted results. But so we participated in Dr. Karen Scott's Sacred Birth study, where they developed a patient-reported experience measure of obstetric racism scale that's validated through the Sacred Birth study. And this scale measures obstetric racism as defined by and with Black birthing people during hospitalization, labor, birth, and postpartum across these 6 domains. And this is a scale that does not require a comparison. You don't have to compare the scores of one group with another group, yet you're still able to pull out obstetric racism. And so by using this instrument and reviewing our results, we were able to identify ways in which obstetric racism also shows up for our Black birthing people. I'm going to very quickly just show some of our perinatal outcomes data. And in order to extract this, so getting to that issue of the EMR, it took me a long time to find the person in our quality department who could pull this data for me. And I mean, it took me like months to find her. But when I found her, what she was able to do, and we use Epic, she used a program called, it's a Midas software extraction program. And through that, she was able to pull data by race. She was not able to pull race and ethnicity data at the same time, though. So that was a challenge. But Epic has, if you use Epic, Epic has come a long way and has specific tools that you can use to look at health equity in the data. So I would reach out to your Epic team about that. I'm just going to show some of the statistically significant differences that we saw. So here for our cases of cesarean birth by racial group, we saw a statistically significant disparity between our patients who identified as Black and patients who identified as white. We saw a significant disparity for blood transfusions between patients who identified as white and Black. And we also saw a significant disparity in newborn mortality for patients who identified statistically as white and Black. One other thing we looked at that I just want to touch on briefly is staff awareness and engagement. And we used a tool that was developed by Burgess and colleagues that looks at provider perspectives and readiness for participation in health equity initiatives. And one of the things it looks at is what do providers attribute disparities to? Do they recognize that healthcare providers play a role in disparities? And looking before and after the initiative, we saw that the numbers of providers who attributed provider behavior to healthcare disparities increased. And so we saw that as an achievement in terms of helping to increase their readiness and willingness to address their role in disparities. So some of my recommendations are to start with data that's already being collected and leverage EHR resources. As I mentioned, Epic has a whole host of resources now around maternal health equity, and other EHRs may have that also. Scrutinize the quality of your data is an important thing, because sometimes we may jump to assumptions, but maybe very few patients have even responded to this, or maybe we need data over a longer period of time. And often because of our population numbers, we do need large data sets to determine statistical significance, but that doesn't mean that we can't determine clinical significance. It's important when we present the data that we contextualize it and try to name the root cause if we can identify that. My outcomes data was largely dismissed as those Black patients are sicker, and that's why we're seeing this trend. And so you really need the context to help your colleagues sometimes understand what's going on, and then have a clear plan for what you'll do with the data. You want it to be actionable as much as possible. These are just two great resources that provide a lot of instructions for how to extract real data. These are some ideas for how to really focus your data use on solutions. And so we're not just presenting data just to present it, but we're really presenting it because we want to develop solutions. So reporting it in an actionable form, uplifting patient and community perspectives when we're determining what data to even measure and what initiatives to take on, acknowledging structural racism whenever we're looking at this data, including stories to bring the data to life and provide more context. Getting qualitative data can be very helpful with that. That's something that the Sacred Birth Study did, and I had actual quotes I could share with my colleagues, and providing clear documentation of how you pull this data so that other units and departments and health systems can do the same. And then from your data, really developing goals, and goals that aren't just, oh, we're going to improve this outcome for all patients, but that have a target that focuses on them being inclusive and equitable, so that we identify what is causing or contributing to this inequity, and then we develop a plan to address that. I'm gonna just keep moving because I'm short on time. The last thing I want to emphasize is that the numbers don't speak for themselves. Often, and I made this assumption that if I show their inequities, everyone is going to be alarmed and moved to take action and fix the problem, but that's not always what happens. And race-based data has been an essential part of racism. So historically, we've used disparities data in order to say that certain groups are biologically, genetically inferior. And because of that, when we look at data by race, one of the things that we sometimes think implicitly is that it reflects racial differences. And it may even confirm this sense of, yes, those people are just sicker, those people just have problems, those people are genetically predisposed to have poorer health. And we have to work really hard to get ourselves out of that, and make sure that we're expressing very clearly that race is a social construct, and really providing strong context for all of that data. And so that was my last slide. And just.
Thank you. That was a terrific presentation. We do have 2 minutes left in the hour, and so we're going to take this time to get ready to close out. But first, I want to say thank you to Dr. Arrington, or Lauren Arrington. I say Dr. Arrington all the time as I'm citing your name, Lauren. So I know that you are midwife, and want to honor and respect that. But we really appreciate all that you've brought to us today. There have been some comments in the chat, many of which are around struggling with being able to have data that is disaggregated or stratified by race, ethnicity, when there are challenges with both self-report and those standardized definitions that are from the federal government, not completely acknowledging who the subpopulation is. And so really understanding the subpopulation. And then the third is also, of course, providing those resources to everyone that is with language concordant, cultural concordant, and with that level of respect. And so that's something we'll come back and talk about again, both at our April summit. So I wanted to quickly say we have our April summit coming up, our spring Penguin Summit on April 12th, and it's all day that Wednesday. We will also have another conversation on data utilization and real data utilization in April for our webinar. And they also, non sequitur, but wanted to say January is Cervical Cancer Awareness Month, and wanted to make sure we take this opportunity to educate our subpopulations, because one of the biggest barriers for cervical cancer screening is exactly what we're talking about in this webinar, which is providing information that is culturally and language appropriate, and making sure that we're able to understand and know who the subpopulations are that are having lower screening rates. So completely in line with what Dr. Arrington is talking about in terms of our data, looking at SMM, we have similar challenges with other health outcomes in relation to utilization of real data. So we are committed to helping all 19 teams participating and more really be able to collect that data, self-reported, utilize that data disaggregated by all of the different demographics that matter to your institution and to your working group, and help you to use that in practice so that we can improve experiences and outcomes for everybody. So just wanted to close out there and say thank you. And we look forward to seeing everybody for our February webinar on the third Tuesday at noon. And Lauren, if you have a few moments to stay on, if you don't mind, we'll chat. That was so fantastic. Thank you so much.